I met my patient, we'll call him Fred, on a Tuesday in July. He was in his hospital room and he had just received the news that he has stomach cancer. He was 58 years old. For the past 15 years, I have been a practicing licensed clinical social worker and palliative and hospice care. So this visit to me felt pretty routine. Most people have heard about hospice care being for the last 6 months of life, but fewer people know about palliative care. Palliative care is a type of medical treatment intended to help alleviate the distressing symptoms associated with a life-threatening or serious illness, regardless of life expectancy. It's provided by a team of healthcare professionals like myself who intend to help the patient manage symptoms like pain, nausea, shortness of breath, even emotional and spiritual counseling. Throughout my years, I have had time to stand at the bedside with crying sons and daughters. I've watched adults of all ages take their final breaths, and I've supported parents as they've told young children about devastating diagnoses. So as you can imagine, people ask me often, how do I talk to someone? What do I say? In fact, this one time my mother called me and she said that her friend's father had had a stroke. And she wanted me to talk to her because she didn't know what to say. But before I knew it, she was handing the phone to her friend, and I am on the hotline. And I didn't know this person. I didn't know what to say. I didn't know anything about her father's stroke. But I get it. It can be so incredibly hard to know what to say. After about 10 years of practicing, I went back to get my PhD in social work. The work that I focus on is informed by my clinical practice in that in many of these situations brought a lot of distress for clinicians as well. So during my PhD, I focused on moral distress, or that feeling of disequilibrium when you can't do the ethical or moral just thing to do. And I wanted to help clinicians have these conversations better. So my research focuses on something called the Serious Illness Conversation Guide. It's a communication tool developed from Ariadne Labs that actually provides the questions and prompts for clinicians to follow. And the idea is that if we can take the pressure off of having to say the exact right thing, then we will have more space for compassion and presence. That's what I want to talk to you all about today. I want to talk to you all about how we might be able to approach these conversations better with more compassion and more empathy. And along the way, you'll hear about my patient, Fred, and hopefully at the end, we'll all walk away with having the moral courage to show up for one another. So when Fred was in the hospital, his reaction to his diagnosis wasn't exactly what you might think. He didn't cry, he didn't ask why me. He simply said it is what it is. It was very matter of fact. We talked about discharge planning, we talked about next steps, about what to expect as his cancer got worse. And then he told me that he was homeless, that every night he stayed at an emergency shelter, and every morning he had to leave per facility rules, not knowing whether or not he could come back. So there he was about to go through something so unimaginably difficult, and he had no place to be sick. And this is where things get hard. These are some of the hardest moments and hardest conversations in healthcare, because what do you say? We want to say something profound, something that lets that person know that we get it, we are listening, we're here for them. But instead we say things like, hang in there, stay positive, thoughts and prayers, everything happens for a reason. And often what's underneath these, what we call pillow messages, my field, we really encourage each other not to say things like this, because what's often underneath is this desire to fix the emotion, to put distance between yourself and the suffering, because the truth is pain is difficult, and watching other people suffer is uncomfortable for us too. It brings up a lot of really difficult feelings. If you've ever been the person on the other side of that conversation, the one going through the hard thing, you know that the one thing you want most is for that person just to listen to your story, just to be present with you, just to sit with you and bear witness to what you're going through. But instead, it can often feel like they just want you to cheer up and not feel so sad, or at least to not show it. And these conversations aren't just ones that we have about death and loss. It's about grief related to lots of things: divorce, job loss, breakups, death of a family pet. But when we're able to be empathic, it's beneficial to everyone involved. In fact, research in social sciences and psychology suggests that when we are able to deliver an empathic response, the person who is providing that response is more likely to engage in pro-social and caring behaviors, like anticipating needs and offering help without being asked. For the person receiving the empathy, you get this sense that you are able to work through what you're going through and make meaning out of it. But when our unchecked and unregulated feelings get in the way, it blocks that connection. The conversation is now no longer about that person's suffering. It's about your own anxiety, about your own feelings of overwhelm, about what to say and what not to say, or a desire to fix it and move on. So before you can really engage compassionately and shape that response to attend to the feelings of the person in front of you, you have to have the moral courage, the courage to address those difficult feelings, to lean into that discomfort instead of away. And when we do that, we can then see the person in front of us. Researchers in neuroscience and philosophy agree that there are at least two types of empathy: cognitive and affective. Cognitive empathy is the sense of sharing an intellectual understanding or perspective of what that other person is going through. So for example, someone comes into a meeting and they're late. You might cognitively empathize with their situation. Something outside of their control has contributed to why they showed up when they did. Affective empathy, and the one that I want to focus on, is about sharing the emotional space with them. So not only understanding that maybe something outside of their control contributed to their time, but also that they might be feeling really anxious or panicked or embarrassed that they showed up late. This space of affective empathy is where we can shape our responses better. Even in the best of intentions, we're going to bring our emotions into it. Sometimes when we see suffering, we look at the person and think, oh, that could be me. But that's not empathy, that's anxiety. Or we see that person and we could think to ourselves, oh, I just am so glad that that's not me. That's the worst one. That's actually pity. And that one comes across as like, I feel bad for you. And without knowing, it creates distance between our situation and theirs, and maybe intentionally, because it can be scary to experience and share the difficult feelings that that person is going through. I have a lot of professional titles, but at the end of the day, I'm a human being, and I have emotion and a desire to care for other people. When I met Fred, I cognitively empathized with him. I knew the right questions to ask. I'd been a practicing clinician for a while. I knew how to talk through it in that moment, but I don't think that I was really affectively empathizing. I wasn't really appreciating the weight of what he was about to go through. Or I did, and it was just too much. There's a desire to avoid, and avoidance is common, but avoidance is ineffective and maladaptive. When we avoid for too long, that distress builds over time, and every interaction that we have carries the avoidance and the suppressed feelings from the previous interaction to it, creating a crescendo effect of distress, ultimately contributing to feeling tired of caring, like with compassion fatigue, or an inability to care, like in burnout. After several weeks, Fred had come back to the hospital, and by this time, he was weaker, he was thinner, he was more despondent, and seeing that change in him was really hard for me. I started coming up with reasons why I didn't need to go see Fred. What he needed was housing, and I didn't have any housing, so what was I gonna be doing there? I can't help him, I can't offer him resources. I felt defensive about my legitimate reasons to not go see him. The problem with that decision is that my sense of helplessness, which was really going on, was leading to avoidance. So what do? How can you lean into the discomfort when every instinct is telling us that we should step away? It starts with awareness. If I took a step back, what I was really feeling with Fred wasn't just helplessness, it was a sense of inadequacy. I wasn't enough. So I sat with that feeling, and for the first time I paid attention to that feeling, and instead of judging it or trying to fix it or push it away, I allowed it to just be there, non-judgmentally, And I just sat with that sense, that quiet fear of not being enough. And then I went back to see Fred. Only this time, when I was asking him the questions I knew how to ask and knew what to say, I felt the feels. And I was with him in his suffering. I asked permission to go there, to talk about the hard parts of his life. What was most important to him? What was he worried about? What was he hopeful for? And something shifted with us. Fred opened up. He told me about his life, what has shaped him. He told me what it was like to go through treatment on the streets with nausea and diarrhea and cramping, with no bathroom, no place private, no place to rest. Nothing about our situation had changed. He was still homeless and dying, and I was still without any resources. But what shifted was our dynamic. And for the first time, Fred wasn't alone in his suffering. I was sitting with him and allowing him that space and time to be seen and dignified and heard. So when we ask, what can we do? This is it. I implore you, lean in and stay present. Questions you can ask. Can we talk about this? What's most important to you? What are you hoping for? And I want to ask each one of you in this room, who in your life right now are you thinking about? Because I have a feeling many of you are thinking about somebody that is going through something tough and you've stepped back from. Maybe unintentionally, but you have. I challenge you to call that person, contact them, talk to them about what's going on with them, be there for them, listen to what they have to say, listen without an agenda. That last hospitalization was the last time I saw Fred. He got discharged to a hotel for about a week before he was then sent back to the emergency shelter, where he died with hospice care. He will never know the impact that he's had on my life, but every time I think about stepping back from a connection when things get hard for me, I think about Fred and I lean in.